Hello, how are you all? Hope you are fine and preparing well for AMC Part 1 examination. This is Dr. Zahra and we are solving some recalls from the Gynae section. So let's start. A 40-year-old woman with a history of tubal ligation present with a complaint of irregular heavy menstrual bleeding. She is known to have multiple uterine fibroids. Other significant point in history is dilatation and curettage 6 months ago with no improvement in her symptoms or no diagnosis for a cause. On examination, the uterus has the size of 12 weeks pregnant uterus. Laboratory studies are significant for hemoglobin level of 8.5 grams per liter. Which one of the following is the next best step in the management? A. Total abdominal hysterectomy. B. Endometrial ablation. C. Myomectomy. D. Combined oral contraceptive pills. E. NSAIDs. So first of all, she is a case of heavy irregular vaginal bleeding which leads to her hemoglobin level falls up to 8.5 grams per liter, and they are asking the best management step. So NSAIDs is not the best management step for this condition. She is having a fibroids which is 12 weeks pregnant uterus. It could be a first line management for heavy menstrual bleeding, along with if the patient is having a complaint of dysmenorrhea and heavy menstrual bleeding, and the question is asking about the dysmenorrhea means pain during menstrual cycle plus heavy menstrual bleeding, and question is about the next line of the management. So NSAIDs can come in that option, but here is NSAIDs is not the good choice to mark because they are asking only for heavy menstrual bleeding and best next line management. So same with oral contraceptive pills. This is not the best management in this condition because she is having anemia because of irregular menstrual bleeding and multiple uterine fibroids. So remember always that fibroids leads to heavy menstrual bleeding. Okay, fibroids leads to heavy menstrual bleeding, and we can treat the symptoms only with NSAIDs, oral contraceptive pill, antifibrinolytics, tranexamic acid. So we can treat this heavy menstrual bleeding with NSAIDs, combined oral contraceptive pills, and antifibrinolytic. But we cannot treat the fibroid. Fibroid need surgery. Fibroid needs surgery. We can treat the symptoms of the fibroids with NSAIDs, combined oral contraceptive pills, and antifibrinolytics and progesterone. We can treat the symptoms, but we cannot remove the fibroid through the medical management. Always remember. So if they are asking the best line management for the fibroids, best management, definitive management, so always there will be a surgery. Okay, now endometrial ablation we can use for heavy menstrual bleeding. Along with, there are some criteria for endometrial ablation. What is the criteria? The uterine size should be less than 3 centimeter. 3 centimeter for endometrial ablation. This big 12 week size of fibroid we cannot treat with the endometrial ablation. So this is wrong option here. Now tie is between myomectomy and total abdominal hysterectomy. Always remember the definitive management. The definitive management is total abdominal hysterectomy. Why this is the definitive management? Because myomectomy, when we are doing myomectomy means we are removing the fibroids, there are always the chances of the recurrence for the fibroid. So total abdominal hysterectomy is the definitive management for the fibroid. Now we have to choose in between total abdominal hysterectomy and myomectomy. When to choose the myomectomy? So if the patient is young, if the patient wants fertility, means she is nulliparous and she want baby in the future, So we cannot go for the total abdominal hysterectomy if the patient is nulliparous, or if she wants pregnancy in future, if she is young age, if she is less than 40 years, or uh, so we can go for the myomectomy. But here is the one clue they have given in the statement. What is the clue to mark the total abdominal hysterectomy and not go for the myomectomy? What is the clue here? They have given that patient is having a history of tubal ligation. Tubal ligation, that's mean the patient don't want a baby. Patient is not planning for a future pregnancy. Patient don't want a baby, so we always have to go for a definitive management for the fibroid. So definitive management is always total abdominal hysterectomy. So I hope this has clear your concept, and we now go for the explanation. Answer is A. Total abdominal hysterectomy. Uterine leiomyomas fibroids are the benign tumor of the uterus. Since histological confirmation of the clinical diagnosis is not necessary in most cases, asymptomatic uterine leiomyomas only require follow-up without any specific intervention. Okay, just remember this line. We will never treat the asymptomatic uterine fibroids. If the fibroids is not giving any problem, even if it is in the uterus or some incidental finding, we have done the ultrasound and some incidental finding, the fibroids are there, but it is not giving any trouble, any problem to the patient, we never treat the uterine leiomyomas. We never go for any medical or surgical management. If the patient is asymptomatic, we only reassure and we only follow up that either it is growing or not. So we never treat the asymptomatic fibroid. Remember this. Symptoms and complication demand intervention. Hysterectomy is the definitive treatment. Other alternatives include myomectomy with various techniques, endometrial ablation, uterine artery embolization. Yes, this is also one of the the treatment for the fibroid. We embolize the artery, uterine artery, so it will stop the blood flow of the fibroids, and fibroids will not grow, and ultimately it's become shrinked because we block the vessels to supply for the fibroid. So this is one of the treatment, but it is contraindicated if the patient is want pregnancy. So we cannot go for the uterine artery embolization. Even endometrial ablation is contraindicated if the patient wants pregnancy, because if the patients get pregnant after endometrial ablation, there are the higher chances that of ectopic pregnancy. There are the higher chances of placenta accreta. So these are the high risk pregnancy. We cannot offer endometrial ablation if the patient wants pregnancy. We can offer only if the patient's completed her family. So these are two options if the patient has completed her family endometrial ablation and uterine artery embolization for the fibroid. So other is myomectomy. I already told you how to decide between the myomectomy and total abdominal hysterectomy. So I hope this video clear your concepts. Thank you very much. Bye bye.